Hello, we are Group 3, and we looked at the use of constraint-induced movement therapy for hemiparetic stroke in the upper extremity compared to traditional rehabilitation. Clinical scenario. Mr. Young is a 68-year-old African-American male who is seeking outpatient occupational therapy services. He had a right hemispheric stroke 9 months ago and wants to increase functioning in his everyday activities. Occupational therapy evaluation revealed that Mr. Young's cognition was intact, posture and balance was within normal limits, and did not show other adverse health concerns. Lack of range of motion in the left upper extremity, his non-dominant hand, was apparent throughout the evaluation. Additionally, manual muscle testing revealed paresis in the left upper extremity, impeding on his ability to do everyday tasks. Mr. Young is a retired minister, but wants to continue to minister on a volunteer basis and be able to take care of himself as independently as possible. He has also expressed to the OT that he has difficulty with everyday tasks and has to compensate with his non-dominant hand. His wife is disabled and is unable to assist him with household chores. Although he has friends willing to help him, Mr. Young would like to take care of himself as independently as possible and not be a burden to his friends and family. Evidence-based question. What is the efficacy of constraint-induced movement therapy compared to traditional rehabilitation in improving functional use of the paretic upper extremity in a 68-year-old adult male with right hemispheric stroke? For our evidence search, the patient had a right hemispheric stroke causing hemiparesis in the left upper extremity. Our intervention is constraint-induced movement therapy, and it will be compared to traditional rehabilitation. The outcomes that we are looking at are functional use of the left upper paretic limb. The databases used to conduct the literature search were CINAHL Plus and OT Seeker, and the following search terms are on the slide.
The inclusion and exclusion criteria is as follows. For inclusion, studies including older adults, stroke survivors with upper limb weakness, articles that include participants with a hemispheric stroke, articles that describe the effects of constraint-induced movement therapy and/or traditional rehab on the paretic upper extremity, articles that use outcome measures relevant to occupational therapy and evaluate the functional use of the paretic upper extremity, articles that describe the effectiveness of constraint-induced movement therapy on a paretic upper extremity. The exclusion criteria that we used were patients who did not receive constraint-induced movement therapy or traditional rehab after a stroke, participants who were not cognitively intact and experienced disruptions in balance, studies including school-aged children and young adults, outcome measures which were outside the scope of occupational therapy practice. So the summary of our evidence. All of the literature supported the use of constraint-induced movement therapy to improve function in the upper limb. Studies showed that constraint-induced movement therapy was beneficial in increasing motor control, strength, dexterity, quality of movement, and decreasing motor impairments. Evidence did support the benefit of constraint-induced movement therapy when the total therapy time was 30 hours or less. There were discrepancies in the short and long-term effects of constraint-induced movement therapy. Although studies showed improvements in functional use and activities of daily living after the treatment. Some studies showed difference between constraint-induced movement therapy and traditional rehab in the long term, while others did not. Clinical bottom line. These articles were relevant to our clinical case based on the following criteria. Population. All of the articles examined the effects of constraint-induced movement therapy for adults. However, most of the participants fell within the older adult population and experienced a stroke that was in the same time frame as Mr. Young. Intervention. Mr. Young's occupational therapist should consider using constraint-induced movement therapy to increase performance in activities of daily living, strength, and range of motion based on the evidence supporting this intervention. Outcome measures. The outcome measures that were used for both constraint-induced movement therapy and traditional rehab. They looked at overall physiological functioning and activities of daily living. These outcome measures included the Functional Independence Measure, Wolf Motor Function Test, Fogel-Mayer Assessment, and the Barthel Index.
The reviewed literature yields evidence supporting the use of constraint-induced movement therapy to improve the use of the upper extremity in stroke victims compared to traditional rehabilitation techniques. These could be useful for various occupational therapy settings, such as in-home health, inpatient, or outpatient environments. Occupational therapists working with stroke patients should consider constraint-induced movement therapy as a method of improving the activities of daily living and physiological functioning in the upper extremity. The reviewed studies have proven optimal outcomes for occupational therapists who utilize constraint-induced movement therapy for stroke survivors with upper limb paresis. It is suggested from the literature that occupational therapy utilizes a moderate intensity to gain the most sufficient short-term effects of constraint-induced movement therapy. Barthel Index and FIM scores across randomized controlled trials imply that occupational therapy should utilize constraint-induced movement therapy with their stroke clients whose goals are oriented towards increasing participation in activities of daily living. Occupational therapists who seek to increase their patients' strength, endurance, dexterity, and motor control in the upper extremity should consider constraint-induced movement therapy due to the significant higher Wolf Manual Functioning Test and FAM scores throughout the revealed literature compared to traditional rehabilitation. In general, the review from the study suggests that this intervention can be strongly considered for patients who have upper limb paresis after a stroke. For continuing education or professional education, OT students are educated on the general use of constraint-induced movement therapy during entry-level schooling. Specialized training in constraint-induced movement therapy is needed to be able to implement this intervention effectively. Future research. Although different methods of constraint-induced movement therapy have been proven to be effective in the rehabilitation of the upper limbs following neurological damage, there still is a lack of evidence that supports a common or standard constraint-induced movement therapy protocol to maximize the treatment effects. The majority of research studies investigating the efficacy of constraint-induced movement therapy lack common methods for the implementation of the treatment, such as duration of therapy, time of treatment sessions, or intensity of therapy. Future research needs to establish a common protocol to maximize the treatment's effects and its long-term outcome after treatment. Research also typically includes participants who are moderately impaired. Inclusion criteria have now adopted certain guidelines. For example, participants in one study had to have at least 10 degrees of extension and no more than 20 degrees of extension at the metaphalangeal joint. There is little evidence to support the positive treatment effects on more severely impaired individuals that may be able to benefit from such treatment but wouldn't meet the inclusion criteria for most research studies today. Clients who did not have cognitive impairments or disruptions in balance after stroke were excluded throughout the research studies. Further research is needed to determine the benefits of constraint-induced movement therapy for stroke victims with these issues. Finally, there is a lack of evidence to support the age and gender effect on constraint-induced movement therapy. Most research studies do not take into account such factors that may impede or expedite the therapy process or affect the long-term outcome.